of people have asked about where the facts and figures have come from, and this is essentially where they have come from. The modeling that was done in the Ministry of Health several weeks ago, in February, in fact, when this first started to blow up. You'll see on that slide that the worst case scenario is that 80% of our islanders will be affected. That percentage is the same figure that governments around the world have been looking at in order to try and get their heads around and begin to plan for what they're going to do to look after their citizens. When we say the worst case, the reason we use that phrase is because we've done an awful lot of things to mitigate that factor, and I will talk about that as we go through the presentation. But these are the figures that shocked everyone, and these are the figures that people have been quoting to you in various parts. When we say 80% affected, figures have varied between 60 and 80, and if you vary that at 60% or 70% or 80%, you'll come across with different outcomes. But we can see on the slide that I hope you're able to see in front of you, 13,000 people would not be affected in Cayman. 52,000 people out of a total of 65,000 would be affected. Those mildly affected or not affected at all would be 84%. So a large proportion of people will get through it. They may be feeling very sick in bed and have a fever and feeling really unwell, but they wouldn't need to go to hospital, and they would make it through it on their own, under their own steam, so to speak. But 4,160 would need hospitalization, and that's likely to be over a 60-day period. That's the prediction, that if you don't do anything, that's the period over which you will have an infection problem. And that's the figure that clearly worried everyone. The last figure speaks for itself, 910 possibly dead in the worst case scenario. That's why we've been working so hard, and that's why we've been so concerned about this right from day one. This is the next slide, and it gives a visual representation of the number of cases that we've had dating back to the first case. Well, it wasn't the first case we know arrived on the island on the 29th of February, but actually the date that the sample was taken and sent to the lab and was the 7th of March. And on the bottom scale, you'll see dates stretching up until mid-April, starting with the 7th of March date. On the left-hand axis, you'll see a scale from 1 to 8. So that first patient on the 7th of March hits the first line, which represents one patient. And then we can see there are more patients as we go through. What the orange line shows is, rather than a cumulative total, what it shows is a 7-day moving average. And that sounds a bit complicated, but basically it's smoothing the line. So instead of all the jagged lines, you actually get a more smoothed approach. And you can see that at the moment, the line is not continuing to rise. It's actually falling a bit, which is good news. It means that the suppression that we have been employing very hard since for the last 3.5, 4 weeks has been working. Next slide, please. Thank you. This is a more complicated diagram, and I first of all want you to focus on the top diagram. You'll see there's a black line that between April and July, it shows a great big rise and a peak up to about 280 on the axis on the left. And that represents the number of intensive care beds that would be needed per 100,000 of the population if you have an explosion of COVID-19 without any mitigating factors, if we don't do anything about it. It also shows a number of other lines which show increasing numbers of mitigating factors or things that can be done in order to suppress the disease. And the bottom one, the green line, is when you put in maximum suppression, which means you close schools, you close universities, you have social distancing, you quarantine people and isolate them when they're sick. And now if you now look at the bottom graph, you can see that that green line shows a peak only at 5 intensive care beds per 100,000 of the population. So that's with a lot of suppression, all of which Cayman has put into place. The difference between the tall black line at about 280 and the green line at 5 intensive care beds per 100,000 is a factor of 56. So we can reduce the effect of the virus by maximal suppression by 56 times, which is huge. I've said before, and I'll say again, we have in Cayman around 50 ICU beds, intensive care beds per 100,000. And with maximum suppression, we only need 5. So we are well provided for intensive care beds in the island. And with maximal suppression, our hospitals will be able to cope. That's what we've hoped for, and that is what we have achieved to date. Our hospitals are not flooded with patients. We've managed to keep people out of the hospitals largely, and those that are there had received good care and are making it through, obviously with the proviso of the first very unfortunate death. The next thing I would like you to look at is what happens in October, November on that graph. So on the top graph, look to October, November, and you can see that even that green line jumps up. And why does it jump up? That's what will happen if the suppression is stopped and we do nothing else. So we will get a resurgence because this is an exceedingly successful virus. It's good at infecting people, it's good at being transmitted from person to person, and it's good at hiding away. So it is one of the most successful viruses that we've ever known to have existed in man, which is why it's producing such a devastating effect even in this century that we're in now, which we all clearly think is the most modern, and it should be, and it is. But it's got the better of us. That is what the government is trying to decide on how to manage, and not just this government, but absolutely every government in the world. How do we prevent the bounce back and the potential deaths, the potential hospital admissions that I showed you on the first slide that was so worrying? We're in the suppression stage, so we're safe, but we need to come up with good plans of how we're going to get out of that situation. Of course, the best answer is going to be a vaccination, which would protect everybody. That's not here yet, and it could well be a year or more until that arrives, if we're able to get it. There's always an if with vaccines. There's never a surety. The last slide I wish to go to is actually to give you a little bit more science about the testing behind this, because testing is likely another way we may be able to fight our way out of the situation that we find ourselves in. On the slide that you can see in front of you, you'll see that viral RNA, the ribose nucleic acid, the viral material that we detect with the polymerase chain reaction. That's what we detect when we look, that's what we use to detect the viral RNA. We can see that that rises very early in the infection. That's what the black line and the orange line are about. Well, the black line, really. The orange line is showing that there are virus particles in the blood. And when there are virus particles in the blood that the body recognizes as being foreign, the body starts to react against them, and it produces immunoglobulins. The first one to be produced is IgM, immunoglobulin M. And that will start to fight the infection immediately, but also the long-term memory of the infection is produced by IgG, immunoglobulin G. And we can see towards the right-hand side of the graph, we have IgM rise first, and then IgG rise later. We know now with this virus that IgG rises and is maximal at around 28 days after an infection. IgM also rises. But as you can see from the graph, it's actually the PCR test that's going to recognize that you have this infection first, because that's the thing that can be detected first by the PCR machine. After that, you may get blood changes to show the IgM and the IgG. The problem with testing for IgM and IgG also, and we are being bombarded at the moment, the ministry and so many other places, by the potential to do mini blood tests and so on and so forth. The problem with the IgM and the IgG is the IgM is not very specific for COVID-19. That means other things can make the test become positive. So that's not really a very good test. The IgG may be a good test to say you've had COVID-19. There again, even so, even the laboratory tests, which are the best tests for IgG, have not been shown to be robust enough to reliably detect it. There's another issue too on that score. Only 90% of people who have COVID-19 get a rise in IgG, so what about the other 10%? This bit of science will resolve itself with time. We're going to have answers about the immunoglobulin testing. They will probably come before the vaccines come. I'm expecting them to come along a lot before the vaccines come, and they may enable us to say this person is probably going to be, has had the infection, is probably going to be safe, and this person is probably not. But that still leaves us with a problem in Cayman, because a lot of the population have not had COVID-19 and therefore won't have had a rise in IgG. You may have heard about this thing called herd immunity. That requires a lot of the population to have had COVID-19, but we've been lucky enough. We've kept people out of the hospitals, so that means that we have kept people from having COVID-19, or else we would have had a lot more people in the hospitals. So we go back to actually the PCR testing, which is the testing that we're doing currently at the Health Services Authority, and the Doctors' Hospital are able to do and will be doing very shortly. And it is through that testing that we may find a way to relax the restrictions that we have and allow people to go back about their normal business. But it's a grand project. It's a big project, you can imagine, in order to do this, not only from the laboratory side of things, but also from the organizational side of things. And it's not a question that we will be able to do the test once and say, you're good to go. As I've said quite a few times before, the test is good on that day, but if COVID-19 is still in the community, and I can assure you it is still in the community, hiding there, when it starts to come up again, we'll still need to get people to isolate, to be quarantined at their own homes, and to put a ring fence around them and all their close contacts. And it is possible that lockdowns will need to be introduced again and again and again in order to try and keep people out of hospitals and to protect them. This is all why we wait for the vaccine.